Thank you very much for the welcome. You can hear me okay, right? Good. And let's see, I'm looking for the clicker to advance.
Should I take it with me? That's the one.
Oh, this is it. Oh, I see. Got it. Thank you. Great. Oh, I just want to acknowledge, I don't want to skip the acknowledgements. I want to acknowledge Olga Chernola. She's a psychopharmacologist at the University of Ottawa and a Ukrainian national, and she's been a steadfast partner in the research that I'm about to present her. So I want to acknowledge her. I also really want to acknowledge the Ukrainian delegation that's here and is working ingeniously and with great courage in an extremely difficult situation. So I want to cover a couple of topics. The first is I want to address the question, if MDMA-assisted therapy was available in Ukraine, would it be cost-effective? Would it be a good use of money? The second question is, what would be the effect if you scaled it up? So I wouldn't even be asking that second question if we didn't think it was cost-effective. So I've already given a little sneak preview of where I'm going in this conversation. But assuming it's cost-effective, what are the large-scale epidemic and economic impacts of making MDMA-assisted therapy available to most of the people who could benefit from it? And then finally, I conclude with some modesty and hesitancy. I conclude with a few thoughts about implications for policy and programs. I say modesty and hesitancy because I do not know much about the Ukrainian public health care system or mental health care system. And I know that Ukraine is functioning under constraints that I can't even imagine. So with that caveat, I will make a couple of recommendations at the end. So psychedelics are mainly illegal. Why are we talking about them at all? So I was going to answer that question, but I'm not going to now because I think that question has been answered quite well in the earlier part of the day, and you've been familiar with the clinical research that shows great promise for these therapies. So instead of elaborating on that, I'm going to do something bad. I'm a health economist, and they don't call it the dismal science for nothing. So I want to inject a little bit of skepticism. So let me just point out that there's only been one psychedelic-assisted therapy that has gotten through to phase 3 trials. That's MDMA for PTSD. And many hearts have been broken by promising early results in phase 2 trials that didn't pan out in phase 3. Furthermore, it's typical for the effectiveness of an intervention to deteriorate in real-world implementation. In other words, the promise that's shown in highly resourced, carefully controlled clinical trials may not show up pragmatically as implemented. Some of the trials have small sample sizes. None of them are blinded, really. So we follow the data, and I just wanted to introduce a little note of caution. Tremendous interest in the development of psychedelic therapies. I'm not going to go into detail here, but each of these points is a new psychedelic compound being developed by one pharma company or another in the United States or Europe. On June 14th, excuse me, August 14th, very precise day, the US Food and Drug Administration will make a decision about whether MDMA will be a legal prescription medicine for the treatment of PTSD. This is a big deal. This is the end of many, many years of hard work on the part of MAPS and Lykos and many others. So we're moving forward. Many believe that we are in fact entering a new era of mental health treatment. And in case you didn't think that I was one of them because I made those cautionary remarks, I also believe that we are in fact moving into an era where new interventions will be available that will make a dramatic difference. I want to back up and talk a little bit about cost-effectiveness analysis. There are probably people here who are expert and others who really don't know anything about it. So just a couple of concepts which will be useful as I go forward. One is I want to distinguish between something being cost-effective and cost-saving. People sometimes conflate them and aren't clear on the distinction. Cost-saving means that the initial cost of a therapy is outweighed by the savings over time because people consume less healthcare costs. So it actually saves money. Cost-effective just means that it's good value for the money relative to other feasible options. So most interventions are cost-effective, but not cost-saving. If it's cost-effective, if it's cost-saving, it's cost-effective, but not everything that's cost-effective is cost-saving. And I make this point particularly because there's kind of this idea that if psychedelic therapies don't save money, that payers won't be interested. And I just want to repeat the point I made before. Lots of therapies are cost-effective, but don't save money. That's not necessarily the standard. Cataract surgery does not save money to the healthcare payer, but it's really good value for the money, so it's cost-effective. The other point, sort of slightly technical point I want to touch on is the definition of a QALY, because I'm going to be talking about them a little bit. It's a measure of health outcome. It stands for quality adjusted life year, and it combines both extra years of life that might result from an intervention and the quality of that life, and it combines that in a synthetic, comprehensive measure of health benefit. So now let's get to the original question. Is MDMA-assisted therapy likely to be cost-effective in Ukraine? So we drew on previous work that we did. So we've published a couple of models on the cost-effectiveness of MDMA-assisted therapy in the United States. And for this analysis, I took information from other countries because there's no information on the cost of PTSD in Ukraine, and in fact, no specific information I'm aware of on, for example, the relative mortality of people in Ukraine who have PTSD, the level of well-being of people who have PTSD specific for Ukraine. So I took information from other countries and projected it onto Ukraine. So for example, this graph on the left side, my left side, shows how we took information on the cost of treating PTSD in other countries and adjusted it by the per capita healthcare spending of those countries relative to Ukraine to make an estimate for Ukraine. And we did that with, see where it says this item here, economic losses, interpolated with data from other countries. We did that for healthcare, which I just mentioned. We also did it for the unemployment effects, productivity losses at work. So productivity losses at work, people have a job, but they either don't show up because they're so affected by their PTSD, or they show up, but they don't get much done. That's called presenteeism. And then a large part of the social cost of PTSD is premature mortality. People die earlier, either due to suicide or other sequelae of PTSD, and the country loses the productivity that otherwise would have been available from that early death. The other thing I want to point out, patient characteristics, pardon me, the trials that have been done by MAPS and Lykos focus on people with severe treatment-resistant and chronic PTSD, and that's what we know, that's what the efficacy data is relevant to, is people in that condition. Because in fact, first-line treatments for PTSD help a lot of people. So we're talking about reserving PTSD for those who are not responding to standard treatments. I'll go quickly through here. Yeah, I mentioned we're using a model that we had already published. our outcomes are cost and net cost. So cost of the therapy and then the net cost, where you adjust that cost by savings in healthcare because people are doing better, right? We measure benefits in terms of qualities, but also the number of deaths averted. And then we solve for cost effectiveness, which is the cost per quality gain. We also look at net monetary benefit, but we don't need to, it's not that relevant for this conversation. So here's a result. The cost per patient who completes the therapy in Ukraine, we estimate to be about $1,362 US. You'll notice that almost all of that is personnel cost. And so just to put in another plug for group therapy, the more we can move toward group therapy, the smaller the portion of the cost that will be personnel costs, right, per person. Okay, so I'm about to give you some results on the cost effectiveness of this therapy in Ukraine, but here's a question. What's cost effective in Ukraine? Like, how can you tell? Like, what would be a measure? This is cost effective, that's not cost effective. We said that cost effectiveness meant good value for the money relative to other options. But there's a problem. There's no agreed upon standard in Ukraine for what would be considered good value. Many other countries also don't have a standard, but Ukraine is one. So we solved it by looking at agreed upon, well-established measures of cost effectiveness in 15 other countries and adjusting it by per capita GDP for Ukraine to estimate what a good threshold for cost effectiveness would be. So this is the results of the analysis we did of these 15 countries, and the average for those, again, adjusted for Ukraine, is about $5,500 per quality gained. So keep that number in mind. Anything less than $5,500 is cost effective. More than that is maybe not so cost effective. So here's some results. Where it says healthcare payer, we're only looking at the perspective of the healthcare payer, that is healthcare costs. On the right side, where we say healthcare payer and societal benefits, partial societal benefits, that's where we're including the productivity costs, the caregiver costs, the premature death costs. So on the left side, we have a cost for 1,000 patients, yes, 1,000 patients, of about $1,200,000 for 1,000 patients. This is assuming that the therapy is only effective for 3 years. That's conservative. That's a little pessimistic. We have early data from the United States that suggests that one session of MDMA-assisted therapy for PTSD is not only, the benefit not only lasts for over 3 years, but actually improves over time, which is kind of unheard of. We're used to benefits decaying over time. That's not what we're seeing. So I feel pretty, confident about the conservativeness. I'm not overstating. I'm not being too optimistic here. If you include the societal benefits, now we've got savings. Okay, so this isn't just cost effect. Now we're in savings territory. We're looking at savings of about $2.7 million per 1,000 patients. Going back to the payer side, the net cost per quality is about $1,600. And remember, anything under about $5,500 per quality is really good. So this is really good. And then if you look on the right side, because it both saves money and generates health benefits, you can't calculate a ratio. It's just dominant, which is super good. That's a technical term. Yeah, you saw that. So we did lots of sensitivity analyses. We made estimates of how reliable all the inputs to the model were, and we assigned distributions to them. And then we ran 10,000 simulations of, as you could imagine, 10,000 patients going through this model and calculating sort of what the the likelihood of getting a cost-effective result is. In other words, I gave you just a kind of base case estimate. Now we're kind of looking at ranges. And here's one way to present this. So again, this is the less favorable scenario where we're just looking at savings in healthcare costs. And what this graph shows is the more you're willing to pay for a QALY, the more likely the intervention is to be cost-effective. So the blue line is MDMA-assisted therapy. And you can see that once you get up to sort of, $2,700, the chances that it's cost-effective begins to approach 100%. And it crosses this threshold that we saw this number earlier, $1,600. So anything after, anything to the right of that indicates that the intervention is cost-effective. Whoop. Yeah, and here, if you include societal costs, the MDMA-assisted therapy is 100% sure to be the cost-effective option. That's what those two lines show. Okay, so we solved for the number of civilians in Ukraine who are eligible for MDMA-assisted therapy. So, and they would meet the inclusion criteria of the LICOS or the MAPS trials. I won't go through it now for a matter of time. We ended up with $5 million. There's reason to think that's a low estimate, and frankly, sadly, it's going up all the time. But we're using this $5 million. We did a similar exercise for military personnel. And then we developed three scenarios for scaling it up. If we assume 25%, 50%, 75% of people are eligible over 10 years. And then we solve for the results. So this is for civilians. If only 25% got it in 10 years, it would save 24,000 lives. If 75% did, it would save like 72,000 lives. And major, major societal savings. These are billions of US dollars. So this is real money. In the interest of time, I'm going to go very quickly through this. We did the same thing with military, and it's basically proportional to the number of military personnel that there are, which is much smaller than the expected number of people with PTSD in the civilian sector. I've already talked about some of the limitations of this analysis. We have no data from Ukraine. So we made our best estimates using information from other countries to model what would happen in Ukraine. We also omitted some major social costs. Substance abuse, we did not value it. Domestic violence, we know, is often implicated with PTSD. Education, and people with PTSD, they can't learn. So you're losing human capital. Involvement with the criminal justice system. We did not include that. If you did, the results would look even better. So, to summarize, MDMA-assisted therapy is likely to be highly cost-effective in Ukraine. And just to recap some of the numbers here, in civilians, over 10 years, it would save about $2.6 billion and 48,000 lives. And then among current military personnel, it would save about 61 million lives, $61 million and about 1,100 lives. The broader societal benefits, the economic impact and the productivity impact significantly outweigh the savings in healthcare. It's really about those broader impacts if you're looking at it from a societal point of view. So here's where I'm going. I'm a little shy to present this, like who am I to tell the people of Ukraine and the experts in this room what to do? But one would be to remove legal restrictions, and I understand from this afternoon that that's already happened, so put a check mark there. Evaluation by the SMDC of the safety and efficacy of MDMA so that it can become a legal medicine. Begin training clinicians, we've talked about that. It's obvious, right? And consider designating MDMA as a legal medicine to treat PTSD. And the one I would add is the one I mentioned earlier, like really consider group therapy and how large the groups can be, because the need is going to be so great and the number of clinicians so few, we need to stretch them as far as possible. That's it. Thank you.